So before introducing our next speaker, let me introduce myself. I am Les Rescorl. I am the CEO and co-founder of Sixth Sense Intelligence. And before introducing Scott, I want to briefly introduce Sixth Sense Intelligence. We are the only decision support partner, which means profitability analysis, labor productivity, financial reporting, founded within the last decade. And we saw an opportunity in the market that we wanted to solve, which is the big task it is to take a data-rich but information-poor organization into transforming it into one that has actionable intelligence, automatically produced, automatically delivered to leaders every single day. And a simplified, dynamic, patient-level analytics is at the core of our platform. Our platform ingests data from every data source, so you've got a single source of truth for all analytics. And these analytics allow you to answer questions that previously have been almost impossible to answer, which generates an ROI not only from the analytics automation savings, but also from revenue enhancement opportunities, all in as little as 60 days. So with that, if you haven't already, please make sure if you need CPE, check in at the iPads in the back of the room. Now I'd like to introduce Scott Anders, Chief Medical Officer, Value-Based Care at Providence Clinical Network. All right, Scott.
Oh, hello. Wow. My voice is not that loud usually. Holy smokes, I apologize. Well, woke you up. Oh my gosh, thank you for the invite. I appreciate it. I kind of wish you guys could grab a drink and come enjoy this and feel like a discussion. I'm not very formal. I'm not very good at being very informal, so I'm going to walk around. I'm going to chat. If you have questions, raise your hands. There's a deck that's available. It's packed with stuff. I'm not going to blow through this. I'm going to try to hit the high points, I think, overall. So I'm Scott. I'm a family physician by training. I've been around. You can see the hair. I've been around since the day of paper. I've also worked in the hospital. I've done the typical medical group, running groups and practices, but also 20 years of pop health. And the last 5 years have been running value-based care for Providence. So Providence, you probably, if you know or don't know, is pretty decent size. It's got seven states. At risk, we have 1.4 million people, and we do about 400 to 500 million in value-based revenue overall. And then we do a couple other things as well. And so my goal today is not to teach finance to finance folks. I'm not that stupid. But hopefully what you do is you come away with, I didn't think of it that way. Well, that's interesting. Oh, that's something I need to go look at. And so I want to kind of do it through the lens of through the eyes of an operator. Because that's what, at the end of the day, I spend 40% of my time on vision, strategy, and what I call medical economic insights. Where do we need to go to leverage our scarce resources to provide the greatest services for a larger and growing population? That's really what I want to kind of provide for this, is some of these, hopefully, uniqueness overall. If I don't get to the end of the slides, it's from an operator standpoint of saying, why do we focus on these areas? Because we know they work. And every time we do the analysis, we come back to the same things, but you can fine-tune those. And so hopefully we can kind of go through that overall. So, all right, let's go. Oh, I got the clicker. All right. Help. Is that you or me? All right, man. Sorry, I'll just raise my hand or something like that, so I don't have to say next slide. All right, appreciate that. So the goal today is hopefully gain this understanding of why we're here today, why we're focused where we're focused. Talk about some uniqueness in this space. I think of it perhaps a little differently than everyone. And I can tell you probably the same thing. If I got, I don't know, I'm trying to change this to a finance thing. This is not going to work as a metaphor, I don't think. But if you got 10 CFOs looking at the same balance sheet, you might have 10 different interpretations of what's going on. I don't know if that's true or not. Maybe it's so cut and dry and the rules are clear that it's going to have the same interpretation. In value-based care, everyone thinks we all have similar things, but we peg things differently. I think of it just a little bit differently, and hopefully that'll come across than what you typically hear of. We're not going to talk about coding, not going to talk about quality, not going to talk about what you typically talk about. What I want to, it's from a leadership perspective from you, from your roles, is how do you think about approaching and why we do this overall. Next slide. That's not going to work. So what I've learned, some big lessons. Without executive support, alignment, and what I call shared crystal goals, it will fail. So you've got to make sure that you're on board with this. It's not a side hustle. And then one size doesn't fit all. The big question is, why can't we just put this system into something else? It's because every system is built differently. Every market has different unique payer relationships, and every system itself has different capabilities. And so while we know the big strategies, we know the big levers, building that onto the system requires a customization. And so that's something to keep in mind as we go forward. And the two other things, too, is this is going to be a game of what I call micro moves. Because we're trying to not just a tale of one change or two transformation, it's three transformations, right? We've got the clinical and finance that have this kind of tug and pull relationship. They've got to kind of go together. So it's going to be this 1,000 micro moves as we incrementally move in a way that we don't kill the bank, we keep the lights open, but we can stay financially viable. But there has to be human transformation. So we need to start thinking differently than what we typically think. Everything we do today, go back and look at your finance, think about your questions, what problem you're solving. I can almost guarantee almost all of it is a throughput conversation. No matter where you are, you're talking about throughput. How much more incremental volume can I get out of this unit to maximize profit? If we change the mindset, we're going to talk about that a little bit, that's going to be incredibly important, and it's hard to do. So let's look at the next slide. All right, so how did we get here? I'm not going to spend too much time on this overall. Let's go to the next slide. So a bunch of things are happening, right? Our population is aging, and as they age, you start to acquire all these chronic conditions. Those chronic conditions start to require care. That care becomes expensive. That expense is translated into onto the systems, and it's reflected with our patients themselves. And you see this exponential growth over the last years, and I think we all know it's getting close to 20% of our GDP. And so that's not very surprising. Next slide. Here's something that's interesting. As we age, though, the workers per beneficiary is dropping. So if you haven't seen this, this is powerful. So then think about it. We need to build the system we're going to be using in 10 to 20 years. If we're happy with the state of affairs, let's not do anything. If we think it's going to burn, we better do something. If we want something different, we got to make changes. That's something to think about from that perspective. So we've got to think about how to leverage tech and AI and think about roles differently to upskill our workforce and expand their capabilities. That's powerful. That's changing. We're going to have a shortage. Just hiring or buying more docs isn't going to do it. We have to get smarter how we actually think about healthcare overall. Next slide. And as we age, I think as the system, what's interesting on the left-hand side, this is 1990, goes all the way up to the late 20s. We can see the prevalence is increasing, and there's a lot of theories, and we could talk a lot about that. In the medical groups, they do talk about this. You know, the rising obesity, the rising inflammatory states, chronic low-grade inflammatory that we have, everything that's going on, all that is cascading into what you see there. All of that, then also on top of that, as we age, again, you start to accumulate chronic conditions. And as you see in the next slide, this comes out, and there's references there if you ever want to take a look at it. And if you do the left click, and then, or the control left click, it'll link you into the PDFs. This comes from China, but we see it in our Medicare population, but I love how it's set out. And what it does is two things. It says as the population grows, as you accumulate chronic conditions, which we do, the healthcare system goes up, which is what you see on the left, and the big red line is the arc of medications. And what shocked me when I saw this, we think of high cost, we think of managing our high-risk patients. You need to do that, but if you want to bend the cost curve, that's not where it's at. To bend the cost curve, you've got to find the rising risk patients. You've got to get those patients who are escalating and intervene to prevent them from becoming high cost. That's tough. I'm just going to put it out there. That is tough to do, right? These are easy. These people have declared themselves if you're high cost. We know who they are. We have the reports. We can define what that looks like. That's super easy. Managing them isn't so easy, but we know who they are. The rising risk is tough, but that's the secret sauce. Whoever figures that out is going to do well. So, Mr. Intelligence Man, that's, if you can figure that out, you guys are going to be, I got a leg up on you. But what shocked me about this from my mind when I looked at this is, look at that, 0, 1, 2, 3, that meteoric rise in the number of medications. And what happens when you add medications? Things happen, right? Untoward side effects, interactions, adverse events, cost, bad things happen. And it's not when you get to 4 to 5 or 6. It happens before you get there. So a lot of people will look at that and say, well, if they get to 5 or 6, we'll start managing those. You've lost the game. You're behind the 8 ball. So start thinking earlier when we start thinking about this overall. Next slide. And what we do to patients hits them in their pocketbook. And so when I start, I kind of think of a couple things overall. I always think of, like 5 things in particular. 4 out of 10 Americans have a chronic condition. 4 out of 10. 4 out of 10 have a mental illness or some kind of behavioral issue. We've got a workforce shortage that we just saw. 80% of what determines health outcomes happens outside the hospital. It has nothing to do with what we do to them. It happens in the green spaces. It happens in the social determinants. It happens if you have food insecurity, all this, right? So when we think about prevention, we got to think of primordial prevention, what happens in the environment that they live in. And what we do to people matters. It's expensive. So, and a good example of that, and that expense in that pocketbook, we know that 2 things in particular, 4 out of 10 Americans can't afford $400 or more emergency medical fund. You go to an ER, that's $400 right there, and you don't have that rainy day. You're in medical debt spirals. What do? We send to collections. You know, it's a business choice, but it does. And if we order a bunch of unnecessary tests, it adds up. Even in Medicare, right? Even in Medicare, they have their copay every time we do something. Unless they're in that first 60 days in a Part A hospital-approved admission, there's money coming out of their pocket. So on the right side, in that, the green is that little green slice is the breakout. That dark blue is what we know. That light blue is what they pay for alternative care, like supplements and acupuncture and I don't know, other type of therapies out there that isn't typically covered. And so patients are becoming consumers. So they're patients. So we interact on a medical basis. You're a patient. You've got that patient relationship. They're part of a system. That's the patient relationship. But when they're sitting home and make that determination, how do I spend my dollar? Do I get this medication or do I get lunch for Johnny? And these are real cases that we've run across. That's consumerism. They're deciding, okay, Johnny's fine, but now I have to decide, do I go to this ER or that ER or this urgent care, or do I wait to get in this primary care? That's the consumer-driven aspect of healthcare. And as our deductibles get higher, and as it gets more expensive, they're going to make more discerning measurements. Patients are becoming more price sensitive. There's obviously a set of patients or a set of people that are price insensitive. They don't care. But most of us are price sensitive. And so we just got to keep that in mind when we do things to people. Next slide. And the last one for the setup. There's a lot of conversations around medical waste and fraud and all that. So this is a meta-analysis. So they basically took a whole bunch of reports. They took a look at it and said, it's not well defined, by the way. People talk about it, but no one's come out and said, this is how we're going to define it. This is how we're going to measure it. There are things out there. They took a look and said, we want to aggregate and understand. And so on the left-hand side, I don't want to get into details too much. There's really 2 points in this. On the left-hand side is kind of the big buckets. And you're all going to get these slides. There's nothing proprietary in here. I'm one of those people, I believe in sharing everything. The more our community knows, the better we do, the better our communities, the better our populations. It's just better. Let's just share. It's not a matter of knowing, it's a matter of execution. That's the differentiator, will and skill of the organization. So share everything. This is all yours. So across that horizontal, left hand to the right hand, is what they call that's the billions that they think is occurring in the US. So that one light says, I can't see it, looks like $800 and some billion. That's what they're estimating, down to like 66 billion. So there's a range. We don't know. No one tracks this. It's difficult. That median is the middle one, and then down below it in parentheses, the per capita cost. Like how much is it adding on this per capita cost when we talk about national healthcare expenditures? So there's a lot of opportunity there when we take a look at it. What's the biggest? Overuse. Doing too much because we're fragmented. We have disparate systems. I order another creatinine or another liver function test, even though it was just done yesterday, but I don't have access to it. I need to know to make a decision today. The patient gets hit twice with 2 different bills. That's overuse. On the right-hand side is Washington, so we're not immune to this. They took a look at and they said, all right, if we looked at choosing 5 wisely and we looked at these other things that we know are low value, like in an asymptomatic person, we do a thyroid test, a TSH. There's no evidence behind that it does anything. That's considered low value. 33% of all care provided was estimated to be low value. So when we think about providing value, the question is are we truly driving what is the best care for patients? Now, the flip side of that is the consumerism being driven with patient experience, and if we want to provide the patient experience and get the high satisfaction scores, and the patient wants the TSH, that occurs too, we know. And so there's this, how do we navigate that? Okay, I think I'm done with kind of the big state of affairs. All right, so what's happened? All right, so there's an evolution across the system. So in the next slide, it takes a look at, I'm going to actually, can we go a couple slides over? 2 more. I want to spend time on this slide. Next one. Yeah, perfect. So no matter what your feelings are on CMS, and people have different feelings on CMS, one thing they know well is they know cost. They know where cost is occurring. If we think about what they do, they don't really have a revenue lever. They have how do you contain and put in programs to affect cost. And so the other big thing that they do is they understand what drives that cost. They're always changing through these actuarial models. They're changing the combinations of these 2 things together. We see causes this increase in utilization, which causes this total cost of care effect on a PMPM basis. So we're going to change, like in the coding, we're going to change the value of that so we focus on it a bit more. And so if we take a look at the march of things, it's been around for a long time. Actually, on the left-hand side of the screen, in 2006, they introduced PQRS. I mean, I was around in that shot, right? That was just pay for reporting. But that was a disaster because most of us were on paper. And I don't even imagine the reams of CMS people they had trying to pull it all together to understand. And they said, okay, in 2011, they introduced the meaningful use, which is we need to start electronically share information and the safety issues and all that. And that's obviously good or bad. But that started before all this. And you can see macro and you can see everything else in the progression. But down on the bottom are the clinical programs that they put in. And they're doing these very intentionally. These are based on cost inflection points that we know within the populations. And they're always tweaking the models from that perspective. So there's a reason, there's an intentionality behind what they're doing. And they started with the end-stage renal treatment program, right? That's one of the first ones that's been out there. The hospital readmission reduction program, the value-based purchasing program, all these are put into place because when they took a look at the aggregate, they know that these are driving the cost from the system perspective. And so we have this march out of what's going on. And I'm going to talk about, I think I'm following something about regulations, and someone talked about what we think is going on. I'll just give you my viewpoint on that, but I am not a politician. I talk to government people. We think we know what's going on, but, well, we have an idea. I'll give you that, but I want to say caveat, it's just really just opinion. So on the right-hand side, though, they marched out and said, we can't sustain this. So by 2030, we're going to have see if I get this right, 100% of every Medicare patient who encounters has a medical encounter, that payment is tied to some kind of outcome. That's not saying 100% are covered under a value-based program. It means that every interaction is going to have a value-based component. Patient satisfaction, total cost of care shared savings, going to have something from that perspective. That's what that means. And they want 50% by commercial and Medicaid. And where CMS goes, everyone else goes. So it's important to follow them because if you think about it, they're the largest single payer in our system. They have this reams of data on patient behavior and how it affects cost. So they know, and that's what these programs are for overall. And whether you agree with that or not, they've developed this glide path. And I'll get to where I think this is going in a moment, but we already do know some things. We know 4 programs are cut. The longest running program's been cut. We do know that these primary care ones have been cut. And so if we go to the next slide. Okay. So if we look at payer status across the system, Medicare, Medicaid, our government programs are the 2 largest payers. And interesting, in the Medicaid space, and I'm talking about Medicare a lot because from a system perspective, and I'm going to talk about this in a moment, a return on value on a per member per basis, either on a PMPM or a per beneficiary per year, your greatest return is going to be in the Medicare space. I'm going to tell you right now. And this you have a capitated commercial product. And you manage it well, then you can do very well from that perspective. And we're talking a range of 20 PM to like $700-800. It's insane what it can be. So we know that most of our care, only 22% of our Medicare patients are not in any kind of value-based payment coverage, right? Either an MSS, ACO, most people are an MA product, or MIPS. It's patients that see a doctor who aren't participating in these other ones. They fall under MIPS unless they're excluded. So we're almost there. So when I talk to hospital people and specialists, I'm like, every time you see someone in the hospital, think of them, they're in a value-based product. Next slide. All right, almost done with this. So what has happened? We see this rapid growth of ACOs. I'm assuming everyone here understands what an ACO is, but for those that, just a quick refresher, it was introduced by Elliot Fisher in 2006 in a discussion of MedPAC with Congress, and then later in a Health Affairs article. Actually interesting, it was an ambulatory focused of hospital intensity or something like that, which is an interesting concept, but it launched all this. It's a relationship between a payer, a healthcare provider, a system, about a defined shared population, and you tie some kind of value or accountable care to that population. That's what an ACO is. That's all it is. And now I'm an ACO organization, right? I'm an ACO. So it's kind of moved into this, like, people are using from the legal term to an entity description. If you have a high-performing network, you can hold multiple ACOs. It's just that singular relationship. That's what an ACO is. So we see this growth in ACOs. This rapid growth. And then when you see that level out, that's when all of a sudden CMS says, we introduced this softly. And what I mean by softly is you can get some upside. There's 0 risk to you. So if you do well, you get something. But there's 0 risk. We're changing the game. We're going to start introducing risk. We have this glide path. We expect people to march over time. And so now they've eventually introduced this enhanced model. We can get 75% upside, 40% downside. And it makes a significant difference. That leveling out is when you start seeing that risk. Healthcare systems are risk adverse by nature. Pretty conservative. And I get it, it makes sense. A lot of challenges for specialty, a lot of challenges for systems. So what happens? Who steps in and fill the voids just like anywhere? Enablers, right? People call them disruptors. We call them, whatever. But these are what we call value-based enablers. These are groups that say, all right, we know it takes a capital investment up front to put in the infrastructure to do this to some degree. We know you don't have it. You guys are burning through cash. We'll front this either through private equity or through venture capital or whatever it is. We'll upfront, but we're going to take a big part of the returns. But you get to start playing in this space. You get to say you get to do it. You build your infrastructure. And so we see all this rapid growth of enablers like Wilvana and Privia and all these. And so I have interesting mixed feelings about them, but there is a place for them overall. And so not surprised by that at all, but moving towards risk. And in this space, and you're going to see this in just a moment, it's important to keep in mind there's this glide path. If you stay forever in just shared savings with just a little bit, with like no risk, you're not going to make any effective organizational behavioral changes. You're going to be stuck in this place forever of like we're doing it, but we're not doing it. We can't invest it. You've got to get to the premium dollar. The premium dollar with upfront capitated payments provides the upfront investment you need to manage the patients. That's where you want to get to. This is just setting you up to get there. It's never meant to stay there. And that's the problem that a lot of organizations do. They're like, woohoo, we're in shared savings with a little bit of savings. And it's a safe place to be, but you're not going to make any substantial changes. I can guarantee that. You're going to be stuck there forever. So, next slide. All right. Our thoughts on this, I think, not too much. We see some changes. The incoming CMMI leader, I think that's the right guy, comes from the private equity world. He likes short, fast, hard-to-find return on investments. So it's going to change the name of the game. And if you guys have done population health, the typical time span is 5 to 7 to 8 years before you see actual true changes in effect. So I don't know how that's going to work, but we've already seen a cutout of the primary care models and all that. But what we do see is two things. So MSSP-ACU, it's in the regulation. Congress has to have there has to be an act of Congress to change it. But CMS is the one who implements it. So there's a wide range of what they can do and interpret the regulations. So it's going to be interesting to see what they do. But we already know a couple things. They're going to push us towards risk. They're going to push risk off the government to us, to the payer. Well, to the payers. The payers will push it to us. So we've got to figure out how to manage risk going forward. Next slide. All right. So what I'd like to do is kind of talk about some payment models. And here's hopefully where we start thinking things about a little bit differently. And maybe you already do this, and maybe this is like old news, and that's cool. All right, so let's kind of walk through some of those. First and foremost, we've got to recognize everything we've done, for the most part, has been built on a fee-for-service chassis, right? We've optimized it. Billing, scheduling, regulations, policies. We talk about throughput in the practices. We talk about, can we turn over this practice so we can see 25 patients versus 24 patients. We do this. And it's not a good or bad thing. It's just is what it is. We've got to recognize that, and that's important. Because if we go to the next slide, when we think about value-based care, it starts shifting the way we think about things. And when we think from that perspective, almost every value-based product is built on the fee-for-service chassis. It's still there. That transactional component's not going to go away. But the way we reframe the issue and the way we think about it, that's where the magic happens. If you start rethinking about what we need to do in this space and recognizing there's a world for both of these, how do they fit in those? That's where we need to start thinking our mind shift. For example, I think from a payment model, a global capitated model for primary care population makes a lot of sense. As we move into the higher specialties, it becomes transactional. It becomes episodic. It becomes as needed. It's not as relationship. And obviously there's a big spectrum between. That is a fee-for-service world, 100%. You could do bundles, you could do episodes. The lower the volume, the harder it's going to get to manage and do well. And so it makes a lot of sense. But you can still manage it from a quality perspective, from a value perspective, of not just driving for profit, but how do you manage the cost of it, which is a different mindset than what we typically take today. Next slide. Okay, so when thinking about finances, I always start with this one from Peter Drucker. I think we all know who he is, the father or grandfather or something like that of managerial organizational change and improvement. So long-range planning isn't about making future decisions, it's about the impact of the decisions we make today. And the reason that's important is in value-based financing, it spans of years. So what's affecting us today, like in the MA space, is what we did 3 years ago, right? It's our performance 3 years ago. It's a survey collected 2 years ago. It's the STARS ratings last year, and it's affecting us today. And so if we think from a MA STARS perspective, we have the 7-year range every year that changes. What we do today is going to affect our finances in 4 years. So how do we understand and project that? And that's just an upfront capitated payment that you get today and you can invest. Everything occurs in arrears. And so how do you match a budget for today and investing today with money you're going to get later? That's still trying to figure out what the right balance and the right approach to that. It's a tough one. And then you have reconciliation processes, which can be up to 2.5 years later. So it becomes very challenging. So next slide. All right, so how many people are familiar with the Healthcare Learning Planning and Action Network? No? Okay. One, okay. All right, I will explain. All right, I thought, okay. So before 2015, I could say I was in a risk product, and people are like, woohoo! And someone else say, I'm in a risk product, but we were talking 2 different languages. There was no common dialect. And so in 2015, they brought a whole bunch of smart people together, and they came up with what they called this HCP land categories, and there's 4 categories. The orange on the left is fee-for-service, right? Pure transactional. Then you have your second category, which is really your pay for reporting, pay for performance, pay for infrastructure. It's again, very transactionally based. It's piecemeal. There's no expectations of any kind of shared savings or organizational change. And then you have this 3A, which is shared savings. Again, no risk. But if you do well, you bend the cost curve, you can share in some of it. And the reason I parse those out on the left side, because that's all about margin. Margin matters in that, right? It's just like everything else that you do, your contribution margin. So the next slide, then on the right-hand side of it, if you pull them apart, you've got the 3B, which is the bottom, shared risk. This is if you do well. So we'll give you more of that shared savings, but if it's negative, you're going to pay us. That's where the risk comes in. And then the right hand, the green, is capitation. That's the premium dollar. That's like whatever you get, whatever you do, you keep. And that's not only just about margin, but it's about the cost to achieve results. That's where things start to get interesting. And so it starts to change behavior. So if we go to the next slide. Where are we today? This is, again, the category. So don't worry about the category so much. Think of them as shared risk and capitated risk. You can see where I circled it in the middle. About 43% of our Medicare Advantage plans are at risk. And we're going to see that shift even more. I can guarantee in about 2 years, we're going to flip. I bet you'll be 2/3. And then traditional Medicare is on the right, and you can see the rise overall. Next slide. And then just some of the different payment models there are. Fee-for-service, of course, we know risk. So this ACO upside, there's no risk. Hey, if you do well, you make some changes, you get a little bit. It's pretty easy. Bundled payments have been around, right? This is like for this episodic care, if you do well for this very confined thing, you get some payments. And then you start getting into capitation, even subcap or capitation, where it says, we're going to give you a certain amount for this population. You're going to provide all claims. You're going to pay for stuff if you're delegated. And whatever's left over, you get to keep. You can do pretty well in those. Just to give an example, we have a plan that services our United, it's called the USFHP, Uniform Services Family Health Plan. Services are military, the retired, the dependents, not the active military, they have prime. 20,000 members. And on that 20,000 members, we made 40 million. That's not bad. Providing high-level quality care. And so that's where the premium dollar is. We had a medical loss ratio of about 70%. And so when managed well, that's where you can do well, and it provides the dollars in return to provide greater infrastructure and support and investment to care for even more patients. That's how it's supposed to work. Next slide. I'm not too excited about this slide. This comes from Medicare. I kind of threw it in just for your awareness that they are pushing not just the population models, but also the bundles and the payment models. So next slide. Okay, so this is where I think it's getting interesting. How to think about it. I think there's 3 ways of the finances. The first one is obviously performance. We typically look at overall VBC dollars. How much did this contract earn, right? Woohoo, we made $5 million on 40,000 people, right? But the next way to take a look at it is if we think about the efficiency. So the next slide has a second way. So go a little deeper. And what I mean by that is, what is your return per member? We talk about PMPM, we talk about PBPY, the per beneficiary per Y. And why does this matter? Give an example. In a lot of products, when we think on a per member per year. So this is all of our savings divided by the membership. What do we get? Capitated commercial can be up in the 15 to 1800s pretty easy. Some, the well-managed, could be 2,000. MA plans can be 1,000 to 1,400. MSSP can be up there as well. We've got some practices that are performing that well. Medicaid drops to about 50. Commercial drops even lower. Commercial is about volume and other things that are going on. So when you think about an efficiency metric, it's not just the total dollars coming in, but from a return perspective as well, on a per member, you start thinking about populations that you're thinking about overall. And then finally, it's not just that. The next slide talks about what is the cost to achieve those results. So do you know what your contribution margins are? And a good example in a place that I worked, we were all excited. We had this product, we made $5 million. And then when we looked at the population we served, and we said, if they were straight fee, or how much did it cost us? Well, we paid $130 million to chase that $5 million. It doesn't make much sense. So that contract, we're like, let's get out of the VBC and let's focus on rates. Let's reduce that. That's the move from that perspective. So understanding how much it costs to obtain those results is incredibly important. There's very few systems that I've been part of that know that and do that exercise. Those that do, it'll be shocking. So these are the three things that I would ask you to think about overall. These are incredible. Next one. Okay, so how does this work overall? 20 minutes, all right. So the other one I would ask about is effective yield. And what I mean by that is if you peg Medicare at 100%, okay, do you know, like in your Medicare Advantage space, how much you're actually getting on a return? And what I mean by that is if you factor in denials, you factor in bad debt, you factor in delays, interest, anything that erodes your return, what is your effective yield? We've had plans that had like a 92% effective yield. So had the patient been in Medicare fee-for-service, we would have earned 8% more. That's eye-opening. So think about that as you're looking at your systems as well. So what can you do? Where does value-based care come in? Next slide. It can be that margin that pushes you over that 100%. So it becomes accretive. It's incrementally additive to your performance overall. So just something to think about. All right, next slide. Not going to get into, there's some slides that go into total cost of care, of how they work. I'm going to avoid those today. It's kind of getting late. I think it's about 4:30. You guys are getting closer, or it's 4:40, getting closer to cocktail hour. But understand how everything works is going to be important. And I want to walk through some of the clinical aspects. So next slide. Oh my gosh. How many people know CMS stars ratings? How many people deal with it? Not a whole lot? I know. Kristen does. Does anyone else deal with the CMS stars ratings and stuff? Not really? I want to know how far to push this. Okay, a little bit. I think the takeaway here is this. Plans bid what they think they can care for the population. CMS says, we'll give some of that bid back if you're underbidding this population. It's called the rebate. And then if you perform quality, the star things, we're gonna give you a little bit more, and it raises everything. That's what on the right-hand side. So for CMS, for an MA plan, their quality performance, and 4.0 is the magic number, and their bid is important because it affects rebate. And that drives your premium. So if we look at the next slide, I don't want to spend too much time this type of day, but kind of read through those and understand. And actually the next slide is the impact. This just goes over the generalities of it. If we look at the next slide, it goes over into what happens. So when a plan drops from a 4.0 to a 3.5, that's huge. I mean, I can't tell you what that means to your system. It's going to hurt you. it's going to hurt. They start taking benefits away from patients. They start restructuring. They start rethinking about things. Your premium gets significantly compressed. It doesn't sound like much, but they lose, their rebate drops, and so that return goes away, and that quality bump that pulls everything up is gone. And in the next slide, and this is, I'm not going to walk through this, but walk through this. Can we go one more further? And this is what happens is if you had a premium of $1,000 and you went from a 4 to 3.5 star, your surplus, that's your shared savings, goes from $80 to $35. You just lost half of your potential surplus. That's a big change. So know who your payer partners are. So when we talk about who they are, it's important to keep a pulse. What percentage of their patient population am I? How is the plan changing next year? And have I put that in my pro forma? Because I can guarantee if you don't do that, when you go into that budget year and all of a sudden your premiums are compressed, you're going to have some interesting conversations with people because you just lost $5 million off your book and you've got to figure out where it went. So, know your star ratings. Next slide. All right. So, the last one I want to kind of hopefully tickle your brains with some kind of clinical things of why, from a operations, like why do we do what we do? And hopefully some reframing of how we approach this thing. So, well, first of all, it's why haven't we made the change? Well, it's complex, it's hard. Incentives drive everything. We're built off of these incentives. We still incentivize docs on volume. We're moving, we're making incremental moves, it's that tug and pull. But it's going to be very complex. All of our IT systems and policies, they're all built on to maximize our volume. And it's not going to be easy. In the lower end, it's probably say most systems are risk adverse. You want a guaranteed return. And I can guarantee there is no clinical program I can put in place that'll guarantee zero risk from a financial standpoint. I can't predict like the next pandemic. I can't predict some other things as well. So that's why they call it risk. It's a risk. And a good friend who's retired spent a lot of time at Optum and some of their programs, and I always say every 5 years a profitable program will not be profitable. So make sure you've got reserves and you just understand that and people are aware of that. Next slide. Next one. That's just it's just some caveats when you're thinking about value-based care. So can we go to the next one? This is one of my favorite slides. I call this the reframing slide. Because to me, it's how you approach things matter. And this goes back to that question of what problem we're trying to solve. If I'm trying to solve how many patients I can get through a practice in a day, that's a volume-based problem. I'm going to focus on that. It's about that. How many units of revenue can this space on a per square basis generate by doing blah, blah, blah. So across the top are strategies. And they're good strategies. They've been strategies I've been part of, and I support all these strategies. Need more primary care docs, that's true, but we just saw that's not happening, they're shrinking. But we need them. Refer internally, system this, right? How many times have you seen or heard that? That's actually a good thing, because when patients go outside the system, there's no insight. Unmanaged patients are risk. So from a total cost of care perspective, it might be better if they go somewhere else if you're an expensive system. But you lose that insight into what's going on, and so it's unmanaged risk. So but it's a good thing, so refer internally. Increase acute care capacity. That one I'm on the fence about, but that's cool. We hear that a lot. I think it's more about efficiency and having the right level of care. Increasing market share makes sense. If you're not growing, you're dying or something like that, right? And high quality, of course, we got to do high quality. So how do you reframe this? This is where it's important. It's not so much more primary care, it's how do we effectively use the primary care we have to care for a population. That's a different question. So we do a lot of team-based care is out there, but it's not team-based care. It's team-based care to get the doctors to see more. That's not team-based care. Team-based care is a proactive approach of how do we care for more patients and preserve that primary care, that very scarcity, that becoming scarce face-to-face time for the patients that need it, so we can take care of more patients in a way that they need to or they want to. Like, we know the younger generation is more about convenience care, asynchronous, using technology, lower risk patients. We don't necessarily need to see them, so how do we decompress? It's a different conversation. Internal referring, it's more about referring for value. Are the patients being seen by the right physician in the right place at the right time for the right reason? I can tell you, we send back pain to neurosurgeons and they don't need to go there. That's a pretty expensive, like, hey, just do some physical therapy. You know, that also hurts the patient's pocketbook, by the way. Capacity thing, to me, it's not about capacity, it's about right-sizing it. It's about, I met with this hospital CEO guy, and I can't believe he said this. He's like, I took this job because the board said I could reduce our admissions, effectively reduce our admissions. What I mean by that is I take care of a broader population, but our volumes stay the same. That's better care. Like, he gets it. And same thing, increasing market share. How do you create an integrated, seamless product? So instead of like saying we need to increase market share, it's better like, what can we do well? What's our core? What can we be the best at? And who do we partner with for those that where we can't be? And for those that are part of Providence, you've heard this, our current CEO is talking about this, and I fully support this. And then, of course, high quality is high value. So reframing is a big part of my conversations with folks. So from a value-based perspective, I'm going to have to talk a little bit about this. So I think the next slide talks about, this is really to say, and a lot of times people say, well, population care is you're at 50,000 feet. You're not talking about the patient. That's not actually true. It starts with the caregivers. We all have to understand why we're doing and what we're doing. That's first and foremost. It goes to that tail of transformation. It's not just clinical and financial, it's human. I can tell you most systems try to put it in tech or processes, they will fail. The human is the most important part, the people transformation. They've got to be part of this. So it starts with our people. And it starts with each individual patient is unique, and we build from there. But each patient is also part of a population. Population is going to be defined many different ways. So I use this as a reminder that it starts with us, it starts with the patients, and then we think about the population. It's not the other way around. Next slide. All right, so here's my weird take on things. How many have heard that value-based care is like quality over cost? Right? People use that a lot. I think that's fine, a bit derivative, but so philosophically you can say it's patient-centric, whole person, right? Mind, body, brain, equitable, timely, safe, all the IOM 6 things that we need to do. That's the philosophical approach. It's kind of pie in the sky. What do you do it tactically? I don't know, but it's up there. It's a good approach. The practical people will say, well, it's tied to outcomes experience, and it's just some kind of reimbursement. I agree with that. I think of it a little bit differently. I think of it in terms of the 4 things on the bottom. It's about accountability. We often forget about that. That's why they called it an ACO, Accountable Care Organization. So when they introduced that, and value-based care by the time was introduced by Porter and group from Harvard, they introduced it in, I can't remember the name of the article now, but it's also 2006. 2006 was the year of value-based and accountable care. So accountable care, we're going to talk about the moment. Driving value is important. If what we do doesn't drive value, we shouldn't be doing it. So I can tell you now in our systems, I won't have the conversations with anyone where we have high quality and high cost. Think of our specialties, our HOPDs, our hospital outpatients. I'm not having that call because that kind of butt heads with strategy. But where I can have conversations is where we have high cost and low value, where our quality is lower than our peers are expected and our costs are high. None of us should stomach that. That's a value-driven conversation, right? Risk, we talk about clinical risk. And then, of course, it's got risk twice. Interesting. Prevention is the other one. It's all about preventing things, really. Can we get upstream? So in the last 8 minutes, next slide. I'm going to talk just a little bit about this one because this is so important. If you enter into your risk-based programs, I can't emphasize enough, it's about accountability. You have to know who your members are, and you have to understand this. There's a difference. So if I sign a contract with Blue Cross Blue Shield right now, fee-for-service, right? Someone comes in, they hit my door in the ER, they hit my door in a primary care practice, surgery, it doesn't matter. They hit my system somewhere. They touch us somewhere. and then become accountable for the care as they're, through that interaction, right? But that patient who's out there up in Everett, I'll never see. They use someone else. They go to somewhere else. I'm not accountable for them whatsoever, right? They're just out there. There's no expectations for that. In accountable care, so in a contract where we share responsibility, we have this defined responsibility, we say, okay, for this 100,000 patients, we're going to give you a per member per month, but you're accountable for all the care. It doesn't matter if they never touch your system, if they're never hit your system. We've had patients say, yeah, oh no, I picked you because it was convenience, but I have no plans on using you. That's unmanaged risk, right? That gets very hard. We're still accountable for their care. And that becomes a challenge, and we know about 10% of contracts, plus or minus, is in this category. So you've got to know who your patients are. And the reason I bring that up is you have to have a program, what we call membership management. So your rosters that you send have to be accurate. You have to manage this attribution list aggressively, and you have to panel them into your process. You have to attach them to a primary care doc. I can't emphasize enough, and we're not even talking about contract optimization today. That's a whole nother ballgame. Your contracts have to align with strategy and support your strategy, and then you've got to manage those contracts aggressively. That's before you even get to the clinical care. A lot of people forget these two steps. All right, so next slide. This is just the value one. A lot of people talk about those. The one in the middle is something you could apply tomorrow. We use it a lot. We're starting to use it more. Is that quality versus cost. This is the one where I was just telling you about the high quality upper right-hand side or lower right-hand side where you've got high cost and high quality. We see that in our surgical specialties a lot. I'm not having that argument with my CSO and my CEO and my CFO. I'm not doing that, right? Because that's a strategy, and the quality is there. So it hurts the patient's pocketbook, but there's so much else going on that we have to address before we start addressing those. So you do see that a lot. So the question is, where do you fight your battles? But none of us should be ever be comfortable with that high cost, that number 4, and low quality. That we just have to root that out. Fortunately, there isn't that much. It's just hard to find, to be honest. It's not easy. All right, next slide. All right, one of my favorite ones. So Desmond Tutu said, at some point we got to stop pulling people out of the river. We just have to go upstream and figure out why they are falling in. Prevention is the key. If we think about it, go to the next slide. This is social determinants, but we'll go to the next one. I got 5 minutes left. A lot going on here. If you have heart disease and you go to a cardiologist, what are they going to do? They're going to put you on 4 medications. You have heart failure. There's 4 medications that have to be optimized to ensure survivability. If you're on one of those medications, your chance of surviving in 5 years is very low, right? That's prevention. That's called tertiary prevention. We want to prevent something bad happen in an event that, but we got to push up that, right? We've got to push up to like the screening. We've got to push up to the prevention and stuff. It's all about how do we create systems, but we're not incentivized to do that. The system isn't incentivized. You do that in these total cost of care contracts, so it's all about prevention. So it's that stuff we can do for policy. I heard there was advocacy and policy discussed earlier. That's where a lot of that helps with access and healthcare overall. And there's also quaternary, which is we do too much to people. And sometimes we do bad things with good intention, but we do too much. So how do we recognize that? Over medications. So I practice in FQHC, which is like a rural health center on steroids. We had a full implemented what's called this Care-Wagner model. It was a geriatric practice. I'm not a geriatrician. I became one fast. And what I learned was, if you take away medications, people love you. I spent most of my time fixing bowel movements and bladder issues and bedtime and bones, the 4 Bs. You do that, you're a god. And then taking away medications. It's so much easier to add and prescribe something for you than it is to take away, because people are afraid, I'm on that for a reason. So we do too much to people. Next slide. This talks about risk, how fluid it is. If there's one takeaway and you want to be stellar, you just want to stand out above else, figure out how to define rising risk and address it. If you're in a total cost of care contract, you'll be head and shoulders above everyone else. And then come talk to me, because I want to learn too. Next slide. Again, more about risk. Not going to spend a whole lot on this. And then the last, let's see, last couple, next one. Next one. There's one in particular I want to get to. Next one. All right, so from a pure functional perspective, if you're like just tactically, you've done all this stuff, what do you need to focus on? It really is these 6 things. I mean, it's blocking and tackling at the end of the day. It's not sexy, it's fundamentals. If there was 3 things I could incentivize people to be access, get the patients in, document properly, and manage their transitions out of a hospital, and quality, of course. You do those well, you're going to be stellar. But the contracts are important. We talked about membership management. And total cost of care is a monster, and it's distracting. And so I want to talk about that just a little bit, of putting some warning signs up to you, saying be very careful when you tread there, because everyone under the sun has every idea under the sun, and everything is a cost. But it's a matter, going back to the medical economic insights. And we were talking before about being data rich but insight poor. So data knowledge, which is accumulation of information, is not understanding. Understanding comes from analytics, comes from analysis. That insight drives the understanding. Understanding provides clarity of where to focus. And it's the most important in this total cost of care, because that's where you can focus your resources. So next slide. I'm sorry, go one more. And again, there is a place for what we call breadth of data analysis, understanding where to go, and then depth. At some point, you've got to dive deep, but you can't dive deep into everything. That's just, no one's got that kind of willpower, unless you can do AI-driven systems. So next slide. I want to end, let's go to the very end one. And these are very real numbers, by the way, if you want to look at total cost of care. Real numbers are percentages, which is pretty consistent across most ACOs, for the categories of spend against the national Medicare cost. So you can see real spend. Next slide. And then the very last slide. One more. Oh, and just go back. Thank you. If you do this well, you can get rewarded for it. So our Health Connect Partners it's been around since 2014. It's our Medicare Shared Savings ACO. We're about the 6th largest, depending how you look at it. Caravan's probably the national largest. They've got 6 products aggregated. They have a crazy number of members. We have about 166,000 members. We earned, you can see the earnings there. We saved U.S. taxpayers $137 million off of those 166,000 patients. We're in enhanced track, so we got 75% of that. Brought home $108 million. So much we broke the bank. They couldn't send it in one check. They had to send it in 2 payments. That was kind of fun. But the return was there. So when done well, it can be significant. But what's most important, had those patients not been in, our contribution margin, our books would have been a lot worse. We would have been even financially, it would have hurt. So there's this increment of that, and it's high quality. The patients got a degree of quality. They had less utilizations, less hospitalizations, less ED visits, less returns to the hospital, less days in the SNF. And so the patients who were part of this product did well overall. So when done well, it can make a difference. Next slide. So here's my last, kind of, hopefully these are things you can think about. So does your value-based reimbursement contracts align with strategy? It's a constant tug and pull. And I can say you can have too many contracts, by the way. Go for quality of relationship with the right payers. Don't go for quantity. It becomes distracting. You can get too many of those contracts. And then, do you know who's in your panel? Here's something interesting. And this is consistent, in our panels, and it matters because it's empanelment, in our PCC, in our primary care physician panels, for our Medicare let's just do our Medicare fee-for-service patients. 74% are attributed to us. That means 26% are in our panel, but they're not attributed to us. So we do all the work. We don't get any incremental return. So from a panel management perspective, do you know that? And what do you do about that? Those 74% that are ours, we get that additive return on a per member, which is about $800. So we got $800 more for each patient. We're not getting that for those patients that aren't ours. And so panel management becomes important. So again, do you know, are you delivering value? And then do you know your cost to achieve this? Most places don't. It'll surprise you. And then however you define your contribution margins, that's, every system has different ones. And then finally, at the end of the day, it's important to remember patients, and we're all patients, we take the path, and providers, we'll take the path of least resistance. So what barriers and friction points are we putting up? So we're getting the undesired results. It's usually the result of something that made it easier to do something else. I go to the ED as my first point of contact because I can't get into the primary care doctor, or the primary care doctor is so far away, or I tried to do their phone tree, and after 15 minutes, I just got frustrated. So it's just easier to go to the urgent care, right? So understanding that is a critical point. So I appreciate it. Thank you so much. There was a lot going on. Hopefully it introduced you to the world of value-based reimbursement and kind of how we think about it. I laugh at this joke. So, they talk about HCC and coding. We didn't talk about today, which affects payment and adjustments. But basically it says, yeah, I'm fine, except for you keep finding problems with me. And the joke is that, when we document things, we talk about things that patients didn't know they had. We talk about it internally. So that's why it's a doctor joke. But we have it in, all right, really bad. We have it and we care for it and we document it, but we don't always necessarily share it. And so that's kind of where this comes from. But all right, well, thank you.